Right. Good afternoon, ladies and gentlemen. Thank you very much for the invitation and for making it possible for me to be here. When I told my wife last night that I was coming to attend this conference, she said, "My God, you know nothing about it." And I said, "Well, that's perfect, isn't it?" I will not be saying anything. I will just be moderating a panel which will include people who know a lot about it. And now I would like to invite them to the stage. First of all, they are Ivan Duškov, Deputy Director of the General Health Insurance Company for Client Services, who is not here and will not be here. Okay, that's a good start. Never mind. But perhaps we have Stanislav Milotinský, Director and Clinical Psychologist at Psyon Clinic. Excellent. Good afternoon and welcome. So there's going to be at least two of us. Let's see if there's going to be three of us. And that's if Mariana Štefková is going to join us, a psychotherapist and member of the working group for the cost-effectiveness study of psychedelic-assisted psychotherapy for treatment-resistant depression. Good afternoon and welcome. That looks promising. And Aleš Tichopád, head of CzechHTA research at the Faculty of Biomedical Engineering of the Czech Technical University and member of the working group for the cost-effectiveness study of psychedelic-assisted psychotherapy for treatment-resistant depression, is also here. Good afternoon. Welcome. Okay, that was the introduction. But in order to start a discussion, we will hear short presentations which our guests prepared. And we will start with Mr. Milotinský. He has prepared a brief presentation. Let's go for it. Whichever way you find more comfortable. Let's have the slides, please. Very good. Okay, we have the slides now. I would like to say a few words about what Psyon does, because we are one of the first innovators in this area in the Czech Republic. And I would like to talk about one of our novel treatments that we have been doing for about 5 years. So briefly about Psyon. Because we are engaged in novel treatment, but especially in healthcare, we need to build on quality and meaningful foundations. We can't just add new therapies and ignore those who have been working well. Therefore, we are providing standard psychiatric, clinical, psychological, and psychotherapeutic care for hundreds of patients every month. For them, such treatment is perfectly adequate. At the same time, we believe that we need to educate more experts and raise their qualifications, and that's why we train younger colleagues. But we also believe that life is one huge shifting area. That's why we have to be innovative, and that's why we are trying to carry out our own studies and research. And we have been aware for a long time of the fact that the efficiency of some existing tools is limited, and that's why we're the first to Europe to implement ketamine-assisted therapy. And about 1,000 patients have already received this treatment. I would like to show you some data which we have collected. You can see two charts. On the left, you can see depressive symptoms. A week after the conclusion of the therapy, and be it depression or PTSD or generalized anxiety disorders, a week after the conclusion of the therapy, we can see a significant drop. The first dot shows where the patients come to us with medium serious depression, and following the treatment, they even leave the spectrum of low depression. And that happens within a few days, and that's clinically very beneficial. And what's also interesting when you look at both charts is that the therapy is durable in time. You can see 1 month, 3 months, or 6 months after treatment. It's still the same. it's still efficient. The figures are also interesting. You can see that the first point was for about 1,000 patients, the last one about 500 patients. Those are really high figures. We are not aware of any other study in the Czech Republic which would have been done using real patients and real figures. And also the figures below are interesting. We can see 0.05 to 0.07, that's the degree of efficiency. We know that in psychotherapy it's 0.3 to 0.5, that's the effect size. And here we can see that it's 0.5 to 0.7. And that's because we work with a sample of people for whom current therapies are not efficient. Therefore, there is a much bigger potential with this type of therapy. It's this efficient. And we can also see through anecdotal secondary data that our patients really experience a return to life. The degree of their invalidity goes down, the quality of their life goes up. And it's also important to note that such a big sample shows that the therapy is well implemented in the healthcare. It is possible to implement it well, and it's also safe, and it's well tolerated. And if I were to sum it up, these are data which show that there is another piece of the palette which is efficient and durable. The symptoms not only go down, but the quality of life goes up. And it's efficient also for treatment-resistant patients. We have been using this therapy for a long time now. We can see that hospitals, outpatients, and other doctors have started implementing this as well. It's undergoing a sort of renaissance. Thank you very much. And now Mariana Štefková will tell us something about cost effectiveness. I'm very curious about the results of your work. Good afternoon. Good late afternoon. I'm really happy that you have stayed with us. I was asked to introduce our working party, our working group, and having listened to our moderator, I was thinking that we will have to try and shorten the title of our working party. However, what is our objective? It is to study the costs for one of the biggest challenges of current psychiatry, which is TRD. Who is behind this group? It's a very heterogeneous group. It includes academics. We have heard the name Professor Horáček many times. It was his idea to put together this group and to start thinking about whether we are able to calculate the cost effectiveness for PAT. And look at it from a different point of view. It's not only about psilocybin, the word that has been heard here and elsewhere in the Czech Republic and Slovakia. It might be worthwhile looking at other psychedelics as well. So it's the first time in history when scientists or academics from Charles University have initiated this sort of process. We started making the calculations even before we had all of the data from all of the clinical studies, clinical trials. We have a representative from the Czech Technical University, and that's Mr. Tichopád, who is here with us. He represents scientists in the Czech Republic. They work with big data, and he's the biggest expert at cost effectiveness in the Czech Republic. And Ms. Pomajzlova is not here with us. She provides another input, another element, and that is the experience of the pharmaceutical companies, people who have led big teams. Lucia was the leader of one of the largest market access teams. In the Czech Republic, they were number one on the pharmaceutical market. Therefore, she brings in the practical experience, how to put drugs on the market in the Czech Republic. We work with the Psyon clinic. They have been very helpful, helping us to set up the calculations for clinical practice data, because they have the largest group of patients at the moment, and they are helping us map out the flow of patients. We have also communicated with clinics which work with clinical trials. I was active in the pharmaceutical industry for more than 30 years. I was the head of departments which worked with clinical data and processed clinical data in order to communicate with authorities and paying agencies. There's no large pharmaceutical entity behind us. Most of us who worked in these companies are elsewhere now. I have my own pharmaceutical practice, have had it for about a year. And the fact that this study can happen, and we will not be showing the results, we will just be talking about how we are planning the study and why. We are thankful to Cyrus, the foundation, because without them, we would not have the investment in order to do the study at all. Let's now quickly move on to why we chose TRD as one of the first diseases, one of the first indications, where we believe we will be able to make these calculations. And we have heard this in a number of contributions. TRD patients are a large part of depressive patients. In the Czech Republic, the Insurance Companies Association assumes that we have some 700,000 patients which suffer from this, and we know that about a third of these patients are not responsive to the current care, to the current therapies. Let's have a look at the definition of TRD. There are two lines: antidepressives with adequate doses. If patients do not respond to two subsequent lines of antidepressants, we can say that they are TRD. It's a very heavy clinical burden because the patients have been in the system for a long time. And ideally, if we follow recommended procedures and we are all informed, it would be 12 to 15 weeks later when we would get to these data. But our data show that patients are in the system for 4 years, sometimes 10 years or more, before they are diagnosed. The patients are polymorbid. There's a high degree of mortality. 10 to 15 patients attempt suicide, and up to 1/3 of patients, which is 4 in 100, complete their suicides. And that has serious consequences for themselves. It's their personal tragedy, and they have to live with it. But obviously, there are consequences for the entire system, both the healthcare system and the social care system. And because the prevalence of the disease is rather high, and because the current drugs are not very efficient, we decided to focus on TRD. I might repeat a lot of what we have heard. However, what's also important to underline is what comes after the but. It is possible to calculate how the therapy should work and how much it might cost. But the other but is that we also come across hurdles in the availability of the system of psychiatric care. The data show you that there's still a shortage of psychiatrists in the Czech Republic. We have heard what the waiting times are, how long it takes for a patient to get to a doctor, and I extrapolated some of these data. However, when it comes to TRD, if we were to calculate the prevalence in our population, we have about 150 TRD patients per psychiatrist. And it's the same when it comes to psychotherapists. Most of them are localized in Prague, about 40%. 40% of psychotherapists. 11% work in the official healthcare system. And the shortage of well-trained experts also means that PAT may not be possible. We need to calculate cost effectiveness. We have to prepare the system. We have to train psychiatrists and psychotherapists. We have to prepare the entire system in order to implement this and face this serious challenge. I've taken up a lot of time, so I will pass the floor on.
Thank you for these insights. And you actually did respect the schedule. And if we look at data, we see that depression actually represents high costs for our society. It can be tens of millions of crowns per year. And also we have many patients suffering from depression that are not actually diagnosed, so they are not part of these data. And how do we actually calculate and assess cost effectiveness and how we can take it into account? This will be said by Mr. Tichopád. Thank you to my colleagues. Thank you to the previous speakers for already giving you the gist of the topic. I'm not sure if I will be able to measure to the dynamics of their presentations. I will keep it a bit more down to earth and will present some Czech data because I had clear instructions to speak about cost effectiveness of psychiatric pharmacotherapy in the context of the Czech reimbursement system. And I generally look at cost effectiveness or at economic aspects of health technologies, including medicines, and I believe that I have a certain insight in the Czech environment in this sense. I represent the Czech Technical University, and we have two working groups. We have ČVUT Health Data Lab and then another working group. And the first group was created due to a collaboration with the Institute of Statistics. We have had an intense collaboration with them for 2 or 3 years, and we work with national data on healthcare services, and we have been using these data for HTA analysis so that we can follow the patient level, and we also want to make these data accessible for other scientific studies. So we anonymize these data so that even if a person looks at the patient level, they cannot actually tell who the person is. And this is my introductory slide showing that innovation in the field of psychedelics are not actually numerous. There haven't been so many new compounds, but esketamine does merit our attention, and I can mention the example of it entering the Czech market. It had to be approved and listed in the reimbursement system. Then there are other topics that resonate, and I understood them even though I am not a psychiatrist. These are depot forms that have to do with improved adherence of patients. Then another topic has to do with digitization of monitoring of medical use or observing patients and moving towards personalized or tailor-made procedures and treatments. Here is a slide I have been using for a long time. to explain a simple principle, to explain how we view clinical benefits today. We can measure different things. We can measure the volume of a tumor. We can measure the number of metastases. We can carry out blood tests. But there has been this interoperable parameter, which is called subjective preference or utility of a certain procedure. And it is between 1 and 0, and it takes into account your health condition and whether it is good or not. Of course, 0 is the worst mark. Let's not speak about whether there are things worse than 0, but in this test, 0 means that nothing goes well, while 1 is the best mark, where everything is fine. This scale has also been used by economists because they have always looked at whether people were willing to pay for certain things. This can go for motorcycles or chocolate or maybe hiring a person who would mow your lawn. It's not important. It's always about using this same scale. So let's look at the trajectory of a person that spends 40 years in perfect health. And during this time, they will generate 40 QALYs, quality-adjusted life years. Then, if this person falls ill, they might spend 15 years as disabled, and then, of course, the quality of life is worse. So they will then generate 9 QALYs, and then later they will just generate 1.5 QALY during the last 5 years when they are bedridden. So during 60 years of life, they will not generate 60 QALYs, but rather 50 QALYs. And we are trying to take this into account while designing our treatment processes. This is the central concept underpinning these therapies, psychedelic-assisted therapies. And there are multiple methods of assessing this. 2 interesting methods are standard gamble and time trade-off. You can try them in practice because, for example, you can ask a person what risk they are willing to undergo. For example, if there is a treatment that has a 70% chance of complete recovery, but at the same time there is a 30% risk of death. And it is actually quite funny to ask these questions to people. We do it with students and we test it with different classrooms. And it is interesting to look at the results, but normally the range of answers is not that different, class from class. And basically you are looking at what risk you are willing to take in order to recover completely. Of course, if you are perfectly healthy, then you are not willing to risk anything. But if you are ill, then it makes sense. Then there is the other principle, the principle of time trade-off. And the question goes like this. How many years in perfect health would you be willing to live instead of 20 years in your current state of health? So these are games that people sometimes do. You can also imagine going to a football match, where you know that there is one person among those thousands, the 3,000 of football fans, and this one person wants to kill. So in this way you can obtain data and then transfer them, and of course it varies nation from nation. For example, you will have different results for France and for the Czech Republic, and you can then compare the data, and it is interesting to see what the results would be in your environment. If we look at the costs, we can distinguish between direct and indirect costs. On the one hand, we have direct costs that are covered by medical insurance or health insurance. This includes the medicines themselves, but also transport to hospital and so on. And then the more interesting thing is the indirect costs. These can be sometimes surprising for payers. These are costs that concern not only the patient, but also people around them. It is, for example, about people who start caring for their relative, and as a result, they cannot work. And right now, we work with different registers that have been linked to the social and economic registers that are created by our Ministry of Social Affairs, and they give us a more holistic perception of the whole thing. Because these indirect costs can have a major role. People end up disabled or even crippled, and this can lead to early retirements, which of course have economic impacts, for example in the case of antipsychotics, but also in other domains. So all of these costs come together, and here I created a very simple scheme. You can have a patient undergoing psychotherapy and also pharmacotherapy, and the costs accumulate, and gradually they create indirect costs as well, because this person feels bad, then they don't go to work, then their parents feel bad, and so on and so forth. Oftentimes, innovative medicines are really costly, so they can represent the main part of the therapy at the beginning. And we can look at the scheme of between and after the therapy, and the question is whether we can scale the costs. It is interesting to look at different modalities that enter into this process. Let's now have a look at the situation in the Czech Republic in terms of reimbursements. These are the data from our official statistic institute responsible for these data, and these are data concerning our health policy. And basically what it says is that we need to have an adequate comparator. For example, here I have listed a treatment A and a treatment B, and they all correspond to a certain number of QALYs. These are data that are required by this authority. So this analysis speaks of cost utility, and it works with QALYs, and you will divide the amount of crowns by the QALYs to see what is more cost effective. Right now, the Czech Republic has an implicit benchmark of 1.2 million per QALY. So if, for example, an innovation costs an extra 1 million crowns per QALY, it is likely to be approved in the Czech Republic. And for years, we have been kind of circling around this benchmark of 1.2 million Czech crowns, and the process starts with an application for approval. Then the procedure is being assessed, and its cost effectiveness is assessed as well. This is the most important aspect of the whole procedure. And of course, it is also assessed whether a certain substance is substitutable, whether it does meet an unmet need, and whether the landscape will have changed after 3 years when it is legal.
I will quickly through the example of esketamine. We have heard that in 2023 the procedure was launched. It continued with an invitation to supplement more data. That's quite common. The procedure is fairly interactive. Comments are submitted. The applicant is invited to provide more data. And in December of the subsequent year, a decision was issued and the maximum price was set. There were two different amounts. The basic amount was 4,357 Czech crowns. That was the maximum price. And reimbursement was set at 4,200. What's interesting? What was the development of the procedure? And this is quite typical. The discussion focused on comparators. What is the natural comparator? What would the patient receive if, at the time when it was decided that they should be getting esketamine, there would be no esketamine? And that's not a trivial question, and that was one of the main comments. Quetiapine was suggested by the applicant for standard treatment of depression. That was apparently not usual. That was a comment of the State Institute. That was resolved in cooperation with experts. Further negotiations followed. More models were created. And then the Institute accepted quetiapine as comparator, and that slightly raised the level of costs for the comparator, which is fairly crucial for the final result. And alternative scenarios were also added into the model. Some of you may know this. These are calculation models based on probability. The Markov model is the most common one. It plays with a certain period. It's usually quite a few years, usually 20 years, which is a fairly long time. And then the model uses cycles to simulate the scenario. And what comes out, apart from a number of other useful pieces of information, is the incremental cost effectiveness ratio. And that's a figure which tells us how much the innovation will cost per one extra QALY. In the system where there is some therapy already, and the regulator takes that, thinks about how much they are willing to pay. Here it's 1.2, and you can see that it has gone way over. The drugs are expensive. And a miracle happened, and the treatment or the reimbursement was approved for various reasons. And they are all listed here. And this might be used as a guideline for the successful entry of other drugs on the market. First of all, it was expert support, clinical evidence, not only from the Czech Republic. As the conference has shown here, there is a lot of background. It's highly beneficial for clients, and the Experts Association was able to prove that. There's a lot of experience from abroad, and a risk-sharing agreement was entered into with the insurance company, and that's a significant factor. That means that the license holder made an agreement with the payer. There was probably some sort of ceiling or a cap for the payment, so that it did not affect the budget. And there was this unmet need aspect, which was acknowledged by the paying agency. So that was one of the examples of a possible market entry, although the area concerned was not on the preferred list. It wasn't oncology, for example. The Act does not really give preference to certain areas, but the decision is focused on the actual procedure, which I have described. And it's about the quality of life plus the calculations. Thank you very much for your attention. Thank you for the presentation, and I'm very happy that you mentioned the indirect costs, because that's something that people don't talk about, because nobody needs to pay for that. But hardly anyone understands that every year in the EU we lose about 4% of working days only because people are not absent at work. People are absent at work. And if we add presenteeism, which is reduced work productivity due to illness or bad mental state, the costs amount to 10,000s of billions crowns only in the Czech Republic. So it's a lot of money, and it may not be easy to work with something that you don't have to pay for in your cost analysis. And that brings me to my first question. Mr. Milotinský, what do you think are the main barriers for novel payments to find their way into the various official documents? When we talk about the industry, the cost effectiveness and this fundamental mathematical exercise is usually quoted as one of the biggest hurdles and biggest challenges. Thank you for the question. I will start on a positive note. In the Czech Republic, we are fairly lucky when it comes to the reimbursement regulation. It's not the same case in every country. When novel treatments bring something new, for example, in psychotherapy, no new approval procedure is required for this particular therapy. We can just simply implement a new method. And that's an advantage compared to other countries, because they often need a separate procedure for each treatment. But there are also limits. When the novel treatment is different in terms of structure, for example, when it's not just one session but 4 or 5 sessions, or if the concept is different, and therefore current training or the system evaluation training is not sufficient. And then it's also the question of operating costs or other costs. And this is the case of PAT. My experience is based on ketamine-assisted therapy. All of those things are different. And if we were able to present some data showing cost effectiveness, it means a fairly challenging cycle. We do not have an adequate body or a place where we could come and say, here's some new therapy. There's a lot of evidence, a lot of scientific evidence. It has been proven to be effective in other countries. Let's talk about implementing this in our system. Entities such as us need to find their own way and start creating a new ecosystem of treatment. How will patients get to know about treatment which is considered toxic or experimental at best? How will doctors get to know about it? How will they know that it might be meaningful? And how will set the price to make it accessible, since there's no adequate reimbursement? And this cycle makes it impossible to implement this treatment in the system or collect any data. And it's something which many companies found too difficult to overcome. It's a bottleneck. And our advantage is that we can cover our services at least partly, but it's still complicated. And if I'm to be hopeful, I would hope that there would be a body which would proactively think about what needs to be changed and what needs to be added. Without that, the costs of the Czech healthcare system will hardly be sustainable. I'm sure Ms. Štefková will want to respond. However, I will ask a supplementary question to save time. You said that one of the biggest challenges of pharmaco-resistant, therapy-resistant depression is early diagnosis. I know that for depression, early diagnosis is crucial. Where does the system fail? Even if the system does capture depressive patients, we are not able to diagnose the next step or the next phase, which is therapy-resisted depression. Treatment-resistant depression. There are different aspects. First of all is accessibility of care. I mentioned that. How quickly will a patient with TRD get to the right therapy? Secondly, TRD is not a specific disease in the international classification. This is something that we are coming back to. Retrospectively, we discovered that we have a TRD patient, and it opens up a lot of questions. For example, recommended procedure. For example, in the Czech Republic, we have done a lot of work on TRD recommended procedures. I can mention Ms. Czechková, or Mo, or Aleš, who adopted some of the recommended procedures or guidelines of the Canadian Psychiatrist Association, but these procedures are not binding, and it's up to each expert to carry out the right diagnosis. And the procedures are really complex. When you look at the various publications, the doctor actually needs to be a pharmacologist. They need to be aware of possible toxicity during the augmentation of the therapy. The therapy can be augmented using different drugs, be they psychotherapeutics or various other forms, for example, ketamine. Therefore, what the patient comes across is that some time needs to elapse before they actually get the treatment. And one more question. Healthcare is usually quoted as an area where there's the largest gap between the current state of knowledge and the textbooks which are used to train doctors or other healthcare workers. And you can see that what we are talking about today, or can you see that what we are talking about today is finding its way into the training system? I think there's a high demand for that. I can't really comment on what you said. However, I believe that targeted education is part of university studies or postgraduate studies, and that's really crucial for doctors to be able to diagnose their patients early. Obviously, if you have any questions, we are not scared of questions in this panel. You can ask your questions. And until you do that, I have another question. You talked about the cost-benefit analysis. There's another dimension which is very difficult to capture. We know that in the Czech Republic, and we have heard it in the previous panels, there are a lot of informal carers. Some 800,000 people informally care for their family members. And one of the reasons for this informal care is mental health, be it among children or grandparents or both. We often talk about the sandwich generation. Is there any way to reflect these impacts in the cost-effectiveness analysis? The impact not only on the diagnosed subjects or patients, but also on their relatives?
Definitely. And I just want to point out that we do not make cost-benefit analyses, but cost-utility analysis. Of course, the other analysis does exist as well, but it is not what we do. And now to the point. Right now, we cannot say that there is a threshold for acceptable costs. You simply can show what real costs are that have to do with a certain diagnosis, costs for the patient, and then costs for their relatives can be measured. And we can do so using scientific methods. But how do we do it? What if this person is not registered, if this is not reimbursed from the public insurance money? If it is not so, it should be monitored or assessed in another way. Right now, our healthcare system relies on health insurance. Procedures are reimbursed by health insurance companies, and these companies reimburse direct healthcare costs. So, for example, the absenteeism costs are not taken into account in these data. But right now, we have first examples of calculating other costs as well. For example, there was a new act in 2022, and one of its provisions says that from a costs that are non-governmental can also be taken into account. This includes costs that have to do with absenteeism or with early retirement and so on. But if such a person, for example, changes their job, if they buy extra products or services that are not reimbursed, then all of this is not calculated. It is not taken into account by the state, which does not mean that it doesn't make sense to try and calculate it as well, because there are these costs, of course. I think I saw 3 hands. I saw Pana Kažmera. It is not that I remember the names of all of our guests here in the hall, but I do remember your name, so please give her the mic. And then I saw another hand and then another. Okay, I will pass you the mic so that it is quicker and more interactive. Hello, I am Kažmer Ladislav, and I am a scientific worker from the National Institute for Mental Health. And I have a short question for Mr. Milotinský regarding the Psyon clinic and their experience there. You have had 1,000 clients. That is a high number. That's beyond debate. And you have been active for 4 years, and you have had a certain impact. You have a 0.5 result for the effect size. So I would like to know about other results. Do you also have negative results, negative side effects, or things that didn't go so well about PAT? Can you give us some examples? Maybe some extra costs that are not always taken into account in different metrics or models. It can be direct or indirect costs. And also I'm interested in negative side effects of PAT from your experience. Thank you. Thank you for this question. I would have loved to answer it, but unfortunately I couldn't hear it because the speaker is turned in the other way. And okay, the question was about adverse side effects of PAT. Well, the adverse effects that we saw correspond to what is described in expert literature. For example, in around 5% of cases, there are cases of nausea or headaches. So this is one category. And then you also have to have a very good indication process. You need to look at somatic and psychological contraindications, because if we haven't taken that into account, we would have much worse results. But luckily, we have been doing it, and that is why our results are so good. Then there is also a non-negligible chance that the state of the patient will worsen for a certain time before it eventually gets better. So it can be tough for a period of time, but for us it is seen as a part of a bigger healing process which is accompanied by 2 trained therapists, and this stage can actually be very helpful, opposite to recreational drug use. And we actually haven't had any serious adverse effects, any serious decompensations and so on. All of this has been solved through our communication processes. Actually, the advantage of ketamine is that it is well tolerated by patients, and I think it is the comparative advantage of ketamine as opposed to other psychedelics. It is relatively pleasant for our patients. Yes, I came here so that you hear me better. My name is Horáček. I'm a psychiatrist, and I have a question for Ivan Duškov, or for Aleš Tichopád, regarding the approval procedures. Psilocybin has been now approved, but the studies are still in process. Can we actually use the cost-utility analysis in order to show what will come next? For example, if we have 4 million crowns for this, it will involve many, many patients. The costs can be really significant. So can this be useful? That is a very good question. And one of the tasks of healthcare and analytical teams is not just to calculate the cost utility or cost effectiveness, because of course it is not unchangeable. You can have different sensibility analyses and different scenarios, and there can be a certain flexibility within the whole process because you can adjust different parameters. For example, the size of the group that takes part in the procedure, which of course will influence the costs for the therapist per hour. And in this way, you can model different scenarios in order to meet certain cost utility thresholds. And for example, the cost per QALY is calculated over the whole length of a human life. So if such a patient returns to their normal working life, they should keep generating value. But of course, the early cost is high. And if we look at cancer patients and terminal stages of diseases patients, then the costs can be really high. It can be tens of thousands or even millions of crowns per one dose of a certain substance. So in this way, we could actually model the whole process where the person receives outpatient care, then they can fully recover and be active. And I would like to see these calculations. But you can also compare these data to patients who do not receive this treatment. So the question is how to pick the comparative group. Should this be patients who undergo therapy but do not take medication, or patients who do take medications but aren't treated? All of these are very interesting questions that could piece together a model of a more holistic approach. And then, of course, the question is what the payers and the policymakers will think about this, and whether they have a certain will to find a solution that would fit. I think your question was very relevant. I would like to say that we should not be afraid of looking at these thresholds because actually, as was seen in the case of esketamine on the slides from Mr. Tichopád, these thresholds